Hey, Deb Getz here, and I'm excited to share with you the evaluative tool that changed my career. It's not the only tool that I use, but it's the one I use most often, and it has allowed me to get patients better faster. I call it Diagnostic Motion Evaluation, and it is a targeted tool that allows me to quickly identify why a patient is unable to achieve their goals, what I can do to help them to achieve their goals, and it even tells me what I can't do to help a particular patient. It saves a ton of time on the evaluation and treatment process, and as a result, I'm able to achieve amazing results quickly and easily. Since I'm targeting my evaluation to patient function, I am able to know that I'm treating what needs to be treated to get the patient better faster. As a result, I'm getting amazing carryover as well. Check it out, let me know what you think, and I hope to see you in one of our upcoming classes.
Diagnostic motion evaluation is one of the most exciting tools that you're going to learn during this presentation. It is invaluable in indicating where a patient is limited in their ability to move. Enjoy the show. So what is diagnostic motion evaluation? It tells a therapist where, that means the location, and whether something is a structural or a non-structural dysfunction. And basically, it tells us where and what we need to treat. Where and what we need to treat. Because as I had mentioned earlier, if someone has a non-structural dysfunction, the treatment is going to be very different than the structural dysfunction. With a structural dysfunction, we will need to mobilize. With a non-structural dysfunction, we might need to stabilize because of the inflammation factor shutting down the core muscles, which are stabilizers. When we're doing diagnostic motion evaluation, the therapist will utilize their senses during various body motions by the patient to determine where and why a dysfunction is occurring in your patient. Principles of diagnostic motion evaluation include the following. When a person is performing an ADL, or active or passive range of motion, the therapist needs to observe where the motion lacks fluidity. That means that motion should be initiated at a particular point, and that motion should be fluid and sequential through each anatomical structure, from where the motion is initiated to where it ends. So I like thinking about a stack of dominoes. And in this picture, we have 8 dominoes. And after domino 1 falls, then domino 2, 3, 4, 5, 6, 7, and 8. And that is the same type of fluid motion that should occur in our body. We, I think, are taught this when we're looking to evaluate the spine, the vertebra of the spine. We want to see movement through each vertebra sequentially. We don't want to see movement occurring at, let's say, cervical level 2 and then moving right to cervical level 7. We've not moved through 2, 3, 4, 5, 6. So what is going to happen is probably hypermobility at cervical level 7 because 2, 3, 4, 5, and 6 are not moving. And hypermobility will cause irritation and inflammation. So that area would not need to be mobilized. What would need to be mobilized are cervical levels 2, 3, 4, 5, and 6. And cervical level 7 would in fact need to be stabilized because it has become hypermobile by compensating for a lack of motion through the cervical spine levels 2 through 6. The second principle is looking at range of motion and seeing where there is a compensation for that range of motion. So when we look at the picture to the right, we'll notice that the patient has dysfunctional range of motion in his left arm. And what we'll see is a winging of his left scapula. Okay, down at the inferior angle, you will see it moving laterally. We also notice a lot of wrinkles at the glenohumeral joint and around the traps on the left shoulder. But what we don't see is movement in the humerus on his left arm. If you notice right around the elbow and maybe even before the elbow, it seems like this individual has difficulty moving into flexion at this particular area. And in fact, there's a place right here. I would almost suspect that this individual has had a humeral fracture at some point in his life that has some structural dysfunctions that are inhibiting his ability to flex his left shoulder. So at the point where the motion becomes compensated for this individual, it would be the point with which his traps would start to fire, or his scapula would become winged, or perhaps his glenohumeral joint will become elevated. Common compensations for shoulder flexion. We see them all the time in our patients. Using diagnostic motion evaluation, the principle states at the point that the compensation occurs is the location of the dysfunctional tissue. And when we move that tissue passively, we would want to see if the compensation still occurs or not. And if it does, then it is a structural dysfunction. It will need to be released. So in this individual, what I would do is I would stabilize this glenohumeral joint that is hypermobile, and I would mobilize this area of the humerus just above his elbow to facilitate quality flexion of the humerus, so compensation does not need to occur at the glenohumeral joint and the scapula. The second principle is when we're looking at open and closed chain motion. Because when we look at open and closed chain motion, our observation and our palpation will occur at different locations. For open chain motion, the observation of the motion will be distal to proximal, meaning that you will begin your observation at the most distal joints that share muscle attachments for the action being performed. So in this picture, we're looking at dorsiflexion. And this is open chain dorsiflexion. And the motion is occurring, typically, we believe, at the ankle. And what we see is that there are muscles or structures of the toes that also cross the ankle. So we will begin our observation at the toes. And when we look at this individual, what we will see is that the toes really have no problem moving in toward dorsiflexion. Okay, in fact, they are compensating for the motion. And what we see here is that there's some knee bending on the left leg. And what I would say is that depending on when that knee started to bend, that would be the location of the dysfunction. So it looks to be that this person's structural or non-structural dysfunctions begin right at the metatarsals, because he is able to bring the toes back in toward the direction of dorsiflexion. However, the metatarsals are not lifting in the direction of dorsiflexion, and he is compensating by bending his knee. So in this individual, I would stabilize his knee, which is the area where he compensates, and mobilize if this is a structural dysfunction. And the way that we would determine that is through passive range of motion and palpation. So I would take this individual and I would palpate each metatarsal head, the distal part of the metatarsal, and determine which area does not move, mobilize there, and stabilize at his knee, and we should see an improved active range of motion occurring in dorsiflexion without compensation at the knee. For closed chain activity, the motion begins proximal to distal, beginning at the most proximal joint that shares a muscle attachment for the action being performed. And in this individual, if we looked at dorsiflexion again, dorsiflexion, the most proximal place that a muscle attachment is that shares the ankle would be at the knee. The gastroc crosses the knee joint posteriorly and attaches to the femoral condyles. So in this case, we would begin our observation and palpation at the knee, meaning does the upper tibia come forward into dorsiflexion, followed by the middle of the tibia and fibula, I should say, down to the ankle, and then through the toes. And if we look at these pictures that are in front of us, when we look at the picture, we notice that this person is actually compensating for a lack of ability to squat by externally rotating his hips. So he probably lacks flexion of the hips and external rotation of the foot and ankle. Again, telling me that he likely lacks dorsiflexion at the foot and ankle. Versus the picture on the right, where this individual has no difficulty coming down into a full squat, He has beautiful dorsiflexion at the foot and ankle, allowing him to come down into a full squat without compensation. Now, looking at this, we don't know whether this is a structural or a non-structural dysfunction because we need to look at passive range of motion. These are both in the pictures active, as most of the pictures have been. The therapist will use a combination of visual, tactile, and verbal skills, meaning we will observe quality, range of motion, and compensation. We can also feel for compensation. So if we see, let's say, the shoulder elevating with flexion, we can place our hands on the shoulder and move the arm in passive range of motion. And at the point that we feel the motion occurring at the shoulder, we could say that that's where the compensation occurs. Or we can do passive range of motion and feel resistance. Now, we've all felt resistance to passive range of motion, particularly in the other example where I would be palpating the metatarsal heads. I would palpate them and try to push them in the direction of dorsiflexion and feel for resistance. So feeling for resistance would be another way to use the diagnostic motion evaluation principles. And lastly, we're going to use our verbal skills. Communication with our patient, particularly when you're beginning using diagnostic motion evaluation and the arms release technique, it is going to be vital to communicate with your patient. And if the patient has good body awareness, you can articulate to them, or they can articulate to you, at what point does the motion become difficult to perform? At what point does the motion become resistive or challenging to achieve? Awkward would be another adjective to use to your patient when communicating with them to determine the location of the resistance, of the dysfunction. And again, when we look at active versus passive range of motion, it will tell us whether or not there is a structural dysfunction or a non-structural dysfunction. Again, a structural dysfunction is an anatomical structure, connective tissue usually, that is physically preventing movement or preventing quality of movement. It is a block, it is a wall, and the only way to get through that wall is through mobilization. A non-structural dysfunction could be one of the other factors that I mentioned earlier. And in that case, we would need to address those situations and treat accordingly in order to achieve quality range of motion. So again, the treatment will be very different when we have a structural versus a non-structural dysfunction. And again, this is why diagnostic motion evaluation is vital to efficient treatment and successful treatment of our patient with good carryover. I mentioned the sensors used in diagnostic motion evaluation in the arms technique. So just to review, visual, when we're observing quality range of motion and compensations. Tactile can be used for passive range of motion. And also, as I mentioned before, if you notice the area of compensation, you can place your hand there and determine if and when movement occurs. And also feeling for the point in range of motion where there's resistance or compensation in the system. And lastly, verbal communication with your patient, asking your patient at what point does the motion become difficult to perform.